Thanks, Kesa and Luke, and also I'm very grateful to ESPR to invite me to give this year's Bent Robson Memorial Lecture. And I was formerly his student and research fellow for nearly 67 years in the later 80s and mid of 50s. I take this opportunity to give a report back as a student to the European teacher, as well as on behalf of a Chinese neonatologist and a neonatal and perinatal community to pay the respectful to the European colleagues. So my talk in the following minutes will be focused on the current neonatal perinatal care system in China, with special emphasis on the perinatal neonatal mortality, preterm birth and mortality, and the perinatal risks that cause infant deaths. And we also involve a current progression in terms of facilities and healthcare insurance that cover all the families, all the newborns, how it impacts on our neonatal work. And also we focus on summarize some of the findings through our nationwide network studies for the incidence, morbidity, and mortality of neonatal respiratory disease, specifically RDS, and the surfactant use, and also give you some evidence of where we are in terms of 50% survival rate of very preterm infants. And the recent years, with increasing economic growth in China, the international media and also the healthcare journals also focusing on the Chinese woman and child healthcare system. And the Lancet published in past 10 years a series of papers focusing on the Chinese woman and children's mortality and the causes. And from this picture, we could see clear trend from the early 90s to over 20 years, the decreasing of the mortality in children under 5 years old, infants, and newborns. Nowadays, in the already industrialized coastal areas, and especially the super cities, the neonatal mortality is already below 5 per 1,000, similar to the general European standard. But in the inland, especially in the remote, mountainous, and the desert regions, or low industrial level, these regions still is up to 25, even 50 per 1,000 live births for the neonatal deaths. This picture shows, according to the regional economy, the type of counties in China, how they look like. The light gray means the rural area with really decent healthcare service, where dark blue means very worst, a very bad service. I think this picture somehow reflecting the general healthcare level in the whole country. But most of the population are virtually living in the area in the east and the middle area, heavily populated. So their living standard and healthcare standard are quite different. From this picture show the cause of the deaths in newborns, postnatal infants, children under 5 years old here, and how they look like. It's very similar to the most of these developing country, where especially in those rural areas with low-level healthcare service, their infant and neonatal mortality is 3 to 5 times higher than the city and urban area and good economic rural area. But the majority of the people are living in so-called small and medium cities, or rural type 1, rural type 2 economic regions that are more representative of the average Chinese healthcare standard, and also the woman and the infant healthcare. The top 3 and top 4 county hospitals had the highest neonatal deaths, low hospital delivery. Many of them were delivered, as shown here, at home, and a high incidence of and the mortality of neonatal asphyxia and prematurity. However, this series of publications in Lancet do not have the data on perinatal neonatal mortality, neither for the incidence of mortality of neonatal diseases, if we take respiratory disease as an example, which is related to the perinatal risk factors. That triggered us to organize many of these studies in order to complementary to these reports. Most of the hospitals in China are government-owned, so that they can be ranked as a public hospital or healthcare center. From the year 2000 up to now, there's a dramatic reduction of maternal deaths during pregnancy and delivery. And also the neonatal tetanus is already eliminated according to WHO examination. This effort mainly by more than 99% of the hospital delivery and high-risk pregnant care centered at level 2 and level 3 hospitals. The government also spent a lot of money in the past 10 years trying to build up maternity or children's hospitals at the low level up to high level regions, and especially in the big city and the small cities. And this investment tend to be accelerated in the past 2 or 3 years. Especially now we have a universal health insurance coverage for all the rural families, and including the newborn babies. This generally, I summarize, is total reimbursement at 4 to 6 times of annual family income per year for those who require hospitalized, and their medication and drug costs mainly at the county level, also called the level 2 hospital. But in some regions, even level 1, the township clinics can also be reimbursed if they seek medical care. And such a cost are shared by 40% by national budget and 40% by provincial government budget, and only 20% borne on the family. And they need to pay annual premium at about, say, 15, 20 euro something, up to maybe 40 euro per head each year. These are the typical regional level 3 hospitals in China. I took this picture almost 8 years ago when we organized some medicinal study. These were the indoor facilities. Nowadays, such a facility even much better than when I took this picture, especially in these recent 2 years. And we organized a regional study for the complete birth population-based neonatal birth situation, including the disease pattern and their mortality. These are the county hospitals in a region called Huai'an, where it's located 500 kilometers north of Shanghai. And this hospital may be regarded as type 1 and the type 2 county healthcare system, according to the Lancet paper. And this is just to show that this region is typical, very close to the national average in terms of the rural versus urban resident ratio, and the GDP and the family income and so on. So we consider such a study might be extrapolated or amplified to the whole national population as an average, and then we may answer these questions as listed here. And this paper is recently available online, free, for you to have a look at the details. And this table shows in this region of 150 hospitals, we found more than 85% of the births were from level 1 and level 2 hospitals, leaving other 15% in the level 3 hospital in that metropolitan city, in which there were high preterm births, low birth weight, multiple births, and birth defect, C-section rate, and maternal complications during pregnancy, and also the high rate of neonatal mortality. And for the maternal complications, mainly the hemorrhage, premature rupture of the membrane, including preterm, and anemia account for the 3 major. That also stands for the high risk in the level 3 hospitals. And there were, from all these births, 2.2% required hospitalized at the level 2 and the level 3 hospitals. We were also able to report stillbirths, including fetal deaths, and also the early neonatal deaths. That means died immediately after birth, but with life sign. For the preterm rate, it's only 3.7%, and these are the stratified by gestational age. If we put birth weight in category, we find that in those as a very low birth weight, they had a high rate of birth defects and maternal complications during pregnancy, high rate of RDS, and neonatal mortality compared to the large babies. The same was true by the gestational age below 32 weeks, as shown here on this column. This table shows the gender difference by gravida and para from all this information we collected from more than 60,000 cases, where the gender difference in the first delivery, second delivery, and third delivery tend to be higher than the average other Asian countries. Generally, the male-female ratio is 116 to 100, which is quite similar to other regions of Asia. So this is a kind of Asia cultural prevalence that also affect daily perinatal and neonatal care regarding the rescue or not rescue issue. And this table shows the order of delivery, and we found the second or above all delivery should have a high risk for preterm birth, low birth weight, and mortality of infants. Multiple births in China before were about 1.2%. Now it's 1.8 because now we have a lot of IVF delivery in level 3 hospitals. And this is a maternal age of delivery related high risk, especially in those below 20 and over 35 years old with high rate of maternal complications and infant mortality. If we take all those with maternal complications during pregnancy as a part compared to those without, it tends to be preterm, low birth weight, birth defects, and the C-section rate and the infant mortality tend to be significantly higher than those without, implying our system in taking care of this perinatal care still not mature yet. And this table shows those newborns after birth requiring the hospitalized treatment. It was almost 11%, or simply every 9 live births, 1 required hospitalized during the neonatal period. Mainly, these are premature born babies. But the local infrastructure to provide hospitalization seems to be working relatively well, but the quality still needs some time to be improved. And for the major disease we had in these hospitalized newborns, mainly the congenital heart disease, intraventral hemorrhage, asphyxia, and RDS, plus many others. For this major disease, RDS, the mortality tends to be below 20% after vigorous respiratory support in the region by the top level 3, level 2 hospitals. And the asphyxia, mainly for severe asphyxia, the mortality has already reduced to below 6% among these patients. And the congenital heart disease is another issue that they can seek operation afterwards in the provincial tertiary hospitals. And this is just for the outcome for all of this in body weight stratified the outcome, either recovered, improved, and went home, or parental decided terminated treatment or transferred to the other level 3 hospitals, or death or gave up, etc. And the cost and the stay. So I summarize this part that this perinatal complication and risk-related neonatal outcome tend to be related to the hospital type, maternal age, delivery type, maternal pregnancy, pathology, and the comorbidity, etc. And the neonatal status tend to be prominent. We have a very low preterm birth. And for the very low birth weight, extreme low birth weight, this percentage even lower than the Western data. These data first time reported internationally according to a regional complete birth population. And I estimate, based on this, I summarize in this table, which is recently published also online in Archive Disease Childhood, the total numbers of preterm births and the related death rate, and a very low birth weight, extremely low birth, etc. How many numbers I estimate in the whole China, and also the fetal death stillbirth numbers, perinatal death rate, neonatal death rate are listed here in order to provoke more research and investigation. And also we hope such a kind of a complete birth population-based vital statistics may be adopted by the national healthcare system for those regions with this kind of possibility. Now I'll move slightly into the clinical studies, how we deal with respiratory failure in clinical settings. This picture shows Dr. Ben Robson first visit China in early 90s, where the Chinese also show in the first few slides, the mortality is rather high in China, where he considered collaboration with Chinese hospital. And by that time, I was able to complete my research work in Stockholm, and I was by the time very proud of myself, published a lot of paper. But eventually, when I come back to China and look at the real clinical settings, I was a little bit disappointed to find out no surfactant, not to say even no ventilator to use. Then we had to come up from the bottom to reshape the clinical settings by organizing some kind of things to build up the capacity. And then later on, my work mainly focused on clinical aspect for the research and education-based effort. And this in Dr. Ben Robson's second visit in Shanghai, and the third time in Beijing, we organized a series of international forum to promote the new concept of using surfactant and respiratory therapy for very sick newborns. And these are the works already published or to be published. And these are the network we have in the whole China. And I just picked up on one of the papers we published last year in Pediatrics, highlighting the mortality rate after the vigorous respiratory therapy, especially for RDS of a very low birth weight, RDS, the mortality by that time was around 43%. But the total, all age of newborns, the RDS mortality and the mortality in all those with respiratory failure should be somewhere around 25%. And also, among those with withdrawal, we noticed that this every death with tube, every clinical death with tube as clinical withdrawal or on hold, not give the aggressive rescue. The main reason are listed here, and the mortality after withdrawal are listed here. So in Chinese scenario, these factors very often affects the clinical caregivers, whether you should do it or you should hold on hold. So, and also our so-called borderline for the viability to rescue the baby generally is at 28 weeks of gestation. Still, this still apply to the daily practice in many parts of China, but not in the major cities already industrialized. So we put it down to somehow around 25 weeks of gestation. Surfactant use by that time, say 4 or 5 years ago, already reached somewhere around 27% in all those with neonatal respiratory failure, and mainly used for RDS, but also used for the other term or near-term newborns with various of lung disease. If you look at the RDS, those with surfactant survival rate is 80% versus 72 not treated by surfactant. We gain 8% of net birth increment. In meconium aspiration syndrome, 10% receive surfactant, and the survival rate is 75 versus 69. Also, we gain 5-6% increment, but not for the pneumonia or sepsis and the lung infection in this category of disease. 50% survival rate for those with surfactant tend to be at 27 weeks, where for those not treated by surfactant, they survive at 29 weeks. So that's borderline between 28 weeks, maybe somehow reasonably accepted by the local surface. And also with the surfactant treatment, we could see all the improvement compared to not treated by surfactant in this disease category. So after series of clinical multi-center study, we were almost find the effect may be contributed by surfactant. If you look at each of the study in the vertical column to see the net gain in survival that give the credit for surfactant, so you will take the time period to compare. Surfactant treatment stands there with a marginal increment, but for those not treated by surfactant, we also gain substantial improvement. This is something very, important to us to understand how to improve the daily care without relying on this very sophisticated or expensive therapy for treatment. The same applies to those RDS of a very low birth weight infant. If you look at here, the vertical difference and this difference over time, we also obtain such a kind of improvement. And by comparing this, we definitely see the capacity increase over time is related to the more RDS in the treatment group, more surfactant use, and more RDS with surfactant, and the length of a stay in hospital is not prolonged, and the cost just marginally increase, and mortality reduction is concrete, and the RDS mortality and the meconium aspiration mortality decrease is also prominent. So we roughly estimate, based on the low proportion of the preterm, that the total neonatal respiratory failure, including term babies, should be somewhere around 150,000 per year. If we take 3 per thousand, or 1/3 of this as a severe RDS, that should be somewhere 50% or 50,000 per year, that requiring vigorous respiratory support, including long-term CPAP or intubation and plus surfactant. The same thing, if I come to this last table, we see the RDS in this, if we give a little bit more with those with severe wet lung caused respiratory failure together, that may come up to 80,000 per year, with 25% as deaths. And for the later preterm and term newborns with RDS, that account for 1/4 of the total RDS. That should take these numbers, and with roughly 5-6% of the mortality. And the meconic aspiration syndrome we discussed this morning should be standing somewhere at this level for the mortality. And the new challenge and the solutions remain. As in China, we are nowadays building up so-called level 3 NICU over 300 cities. And the units may be 400 and 500 in total at the low level, so-called subprovincial level. And also the neonatal ward in county hospitals, level 2, should be over 3,000. Usually some of them, maybe 20% or 10% should have a kind of level 3 NICU. And the in-hospital delivery and resuscitation need to be standardized. And the increasing CPAP and surfactant use is now our daily agenda. And the physician-nurse bed ratio may be altered to have a more nursing staff put into the surface. And currently, the total capacity for all of these requiring intensive care and requiring rigorous respiratory support is only about 50% or less in whole country. So we estimate another 50% increment at the current level over the next decade. And for those of RDS, such a treatment survival rate should be definitely improved to 80% plus quality improvement in the neonatal care. So I stop my presentation of scientific data, just spend the last few minutes talking about my impression with Ben Robson. And the first time I met him was in the end of September 1987. He brought me to a small restaurant near his home in Odenplan in Stockholm, where I forgot what we ate, but 2 questions he asked me I remember very clear. One is he said he liked the philosophy of Taoism by Lao Tzu, in Chinese oldest philosopher who summarized all this philosophy in the very long time ago, almost 2,500 years ago, that by lowering your bowl below the table edge, the water will come down to your bowl. This is the way how to be a scholar should behave, to be humble. Another factor he mentioned is he is very impressive for the so-called Mao's Red Army long march to overcome so many unbearable difficulty, eventually achieve their success. Is persistence in one's lifetime for the target. So these 2 questions all the time in my mind, I always remember. And to the very last moment, I met him twice in 2007-8. We discussed, last conversation, we discussed the recent progression in the extremely low birth weight survival. I suppose that was at the time when Swedish report for this express study for the world in the world literature first time reported 50% survival in 23 weeks gestation, and he discussed with me for this where China is standing. Second is by some new technology like head cooling or nitric oxide, the benefits or cost compared to surfactant in this. And I feel bitterness when I received the invitation from Dr. Grayson if I could give this talk, because Ben Roberts is no longer with us physically, but his spirit and his mission we still inherit and we carry on. And I hope this my talk is as a student to European teacher could somehow please my sadness. Thank you for your attention, and thank you very much.